Who's ever typing, can you mute?
Yeah, sorry, that's me.
Right, we are live. Fantastic. Welcome everyone to this first, hopefully of many webinars that the Let's Do Digital and the Mind the Bleep team are doing on digital healthcare. And this topic of this webinar is Introduction to Health Informatics. There's many different names for this specialty: clinical informatics, health informatics, and so on. You pick your choice, but basically it's how does digital and healthcare work together to make things hopefully better for the patients and the healthcare staff that are involved with said patients. Now, we've got three fantastic speakers with us today from very different backgrounds. I'm going to let them all introduce themselves, and then we'll kick off with some questions. Now, if anyone in the audience has any questions, please do ask them straight away, and I will pick them out as we go along. We're not going to have a Q&A at the end. This is quite an informal chat. I think it was about like a chat down the pub. It's for you guys to find out about what are we about and how do we get here and how could you get here as well. And, you know, we can point you in the right directions to different things. Anyway, first of all, let's hear from Paul Drake, Mr. Paul Drake, who's calling in from East Grinstead.
Hi everyone, my name is Paul Drake. I'm a consultant plastic surgeon. I'm the clinical lead of the burns service at East Grinstead, and I'm the Chief Clinical Information Officer.
Fantastic, thank you, Paul. And Dom Main, who's in London right now at his office in a little phone booth. Can you tell us all about yourself?
My office is the little phone booth. They just trapped me in here now. Hi everybody, nice to be here. Thanks, Mark. So I'm a GP. But I'm also a product manager and software engineer at Health Tech One, and we do automation for primary care admin. And I've basically just been a nerd since school and uni, and so I've tried to sort of combine all the different nerderies together. So nice to be here.
Fantastic. Definitely thumbs up for that one. Now, I'm not going to put thumbs up because apparently if you do hand gestures on this system, it starts doing interesting light shows and stuff. And maybe Dom will just show you that when he gets a bit bored later.
Sorry.
We like having fun here. And we've got Chris as well, who's joining us. Are you in Ireland at the moment?
That's right, Mark. Thank you. Yep, Chris Wilson here. I'm an NHS GP in Northern Ireland and also a digital health fellow with Elephant Healthcare, who make electronic health record software. So that's me.
Fantastic. And I thought to give everyone a bit of an idea where I'm coming from. So I'm a locum respiratory consultant and a clinician who codes. Like the other three here, we like actually building things that we use in terms of functionality or data. I've just started a new company in London, Bridge, called Linda's Health, working with a fantastic team here, very interesting stuff going on here. And just sort of further background is I used to be the chair of the Faculty of Clinical Informatics, and also a board member for the NHS PyCon. So anyone else out there that's interested in Python, which is a programming language, just, you know, have a chat with myself and the team, and we can sort of see where we can take things together. Right. So yeah, if anyone has any questions, please do just throw them into the chat. But I'm going to start with Chris, actually. What inspired you to pursue a career that combines both medicine and digital healthcare?
Thanks, Mark. Well, I think I always liked medicine because I enjoyed science, and that seemed like a very good way to use it. And as I got to work in the NHS, I realized that we could probably be using technology better to help make the jobs easier. And so I always had an interest in tech, but it was only in about 2015 I started teaching myself to code, and then realized that you can actually do some quite useful things with this. And that sort of inspired me to get involved from there. So I think the classic thing of seeing a problem or how things possibly could be better and imagining a solution. Not that it's always as simple as that, but I think that's what's inspired me. Yeah.
Fantastic. Now, Paul, you and me worked together for a short while last year when I was locuming in the sleep department out there, and I got to hear a lot about the interesting history at Queen Victoria Hospital in East Grinstead, all the plastic surgery they did around sort of World War II and so on. You as a plastic surgeon do things that I just can't even fathom, but I was just wondering, what kind of transferable skills did you get from, you know, your surgical training of plastic surgery and so on that helped you in the sort of digital landscape and your sort of CCIO work as well at the hospital?
Yeah, I mean, I'm not sure what skills. I missed a little bit of your question there. You're saying what skills from plastic surgery?
Yeah, surgery and plastic surgery. What transferable skills have you brought just from that area into this other world of digital health?
I mean, I suppose a lot of it, there aren't any direct skills that you can bring across, really. Surgery is a very practical specialty. One of the things about plastic surgery is that it is very wide-ranging. So we treat a whole range of conditions on every part of the body in adults and children. So one of the I suppose the transferable skills is looking at how you can apply certain techniques to be reused. So, plastic surgery isn't one operation for one thing. It's a whole host of techniques that can be used to solve problems in different ways. And I suppose that's where there's some parallel with digital health and with coding, because that's what it's all about. You find what is the problem, what are the tools you've got to fix it with, and what is going to be the best solution out of the 4 or 5 different options that you have. So I suppose that's one of the things that plastic surgery can bring to it. And in my role as the Chief Clinical Information Officer, it's not a practical tech role. So in that role, I don't write code for anything. I don't produce solutions. But what I do is provide assurance and governance and appraisal of what the best solutions are going to be, and then how that's to be applied and implemented in the organisation.
Oh, very interesting. And for all those new people to the scene with digital health, the CCIO, so the Chief Clinical Informatics Officer, is basically the boss of the shop, shall we say. It's the thing that everyone seems to aspire to. There's a lot of work being done around the definition of who that is and what they do, and the job description and the teaching around that as well. Now, there are other sort of levels sort of around that, and in the FCI, the Faculty of Clinical Informatics, we talked about the office of the CCIO and all the other team members in there, but sort of the next level down. But I think people try and keep a flat structure. You've got your CXIO, so X being P, N, and so on, so pharmacists, nurses, and so on. So you've got chief specialists, as in not just medical specialties, but nursing, pharmacy, midwives, and so on. You have a CNIO, don't you, at East Grinstead, if I remember. Is there any other specialties you have? I can't remember.
No, it's just a CNIO, so we have a Chief Nursing Information Officer, and like I say, we try and keep that hierarchy completely flat. So, we're not in charge of each other, but what we do is try and make sure we have a united front and a very clear vision of what we want to do, so that we can provide the direction and assurance to the organisation on all things digital and how it should be done.
Fantastic. I have one more question for Paul, and I haven't forgotten about you, Dom, at all. So I know that you and Simon, your nurse, isn't it, are both interested in the programming language R.
Yeah.
If you could talk to people about why you got into that, and if in any way it's helpful for what you're doing, though. I think you kind of mentioned you're not really involved with the code, but is it actually helpful in your sort of work as a clinical informatician?
Yeah, I think R, a bit like Python, is a very useful thing to know. And I think in some respects, it's sometimes a little bit easier to see why, because R is fundamentally a statistical programming language. So anyone who's coming through university and medical training will have to learn some sort of statistics, even if it's just the basic stuff. And one of the benefits of R is that not only is it a statistical language, but it's also machine learning, mathematics, data visualization, even web applications can be built in R. And it's all using the same language, the same tools, just with different packages and functions that you can use to build these things. So from my point of view, it's very useful because with one language, I can do all the data science stuff that I want to do. I can prepare presentations with interactive real-time charts within them. I can produce a web app if I want to, and it's all from that same code base without having to learn something else. And it's not to say it's the only way to do it. There's always a lot of rivalry between R and Python, but of course the two can work in tandem, and they both do their own things very well. In some respects, Python could be better for other stuff, and R is good for what it does. But it's an evolving ecosystem. It's a growing language. It's open source, so it really fits the scientific method paradigm. So yeah. Highly recommended. And of course, we have a thriving NHS-R community, which often has NHS Python links within it as well. And they have a conference every year, which is really well attended, with lots of very interesting health-related tech work going on.
Fantastic. Thank you so much, Paul. Now, Dom, over to you. So you and me met quite a few years ago. I think it's through the FCI and a sort of a common colleague that we both know, Dr. Anita Pung, who should be listening right now, she tells me. And you've been working at Health Tech One now for just under 2 years, I think we discussed, and it's really exciting. I had a visit to your offices a few months back. Really interesting what you're doing out there. I was wondering if you could tell me, or tell everyone that's listening, a bit about the sort of automation stuff you're doing, which, there's a lot of admin-y stuff basically that us clinicians have to do, and it can be boring, it can be tedious, it can be unsafe stuff that we get wrong. We're just tired and repetitively saying yes, that blood test's fine, and one of them is not. So I wonder if you could tell me a bit about the sort of stuff you're doing at Health Tech One, how you got involved with that, and how it's improving, patient care.
Yeah, of course. Thanks, Mark. So I guess there's a few things in there, aren't there? One is automation as a thing. I mean, it's kind of unsexy, but basically a lot of the work we do is really repetitive, and as you say, and so if you're doing the same thing umpteen times in a particular system, then you can make that somehow automatic with a few rules around it, on a very basic level. And a lot of the systems we work with in medicine are really bad, but by systems I don't just mean the hospital as a whole, but the sort of individual software packages and things that we have to use as clinicians day to day are very bad. I think the same is true in the laboratories themselves, where the software they have to use is from the 90s. They might have been quite good when they first came out 15-20 years ago, but now they're really quite terrible. And coming from using modern software, modern websites and things, it's really quite frustrating, like, how much they slow you down. You're trying to do your work, and you're being held back by terrible tools. And that really kind of annoys me. I hate doing the same thing twice. And I was very motivated by kind of this feeling that every single doctor, obviously, as a GP, I can relate directly to that, but other healthcare staff as well, is kind of working at 50% or less capacity because of the systems that they're having to use. It's not just software, but software is a big part of that, and everything in some ways. Everything is data, everything is software, and so increasingly it will be true that will be held back by these limitations of these systems. And so I started tinkering around when I was working as a GP with kind of what I could do on my own system. And there's I think there's the CCIOs in the room might get scared by this, so sorry Paul, but there's I wasn't sending any data anywhere, so I think it's okay. But there's a tool called AutoHotkey, which is a great little, Mark's the fan of this.
I've used it. Yeah,
it's a really basic scripting language, so you can write it's code, but it's so basic that it's really very open to anyone playing with it. And what you can do is just automate things like key presses and mouse clicks, on bits of the screen or on certain parts of certain programs. And I realized that there were lots of things that I was doing in my clinical system when I was working every day as a GP that took like 6 or 7 mouse clicks every single time to do the same thing. And it might sound like not very much, but if you do that 100 times a day, it really starts to drive you mad, and it gives you RSI. And I want to be angry at things that I can change, not things that I can't. So I spent a bit of time, genuinely a couple of hours, it was an hour over lunch one day, and wrote a little script that gave me hotkeys for all sorts of things in the clinical system. And it was both very satisfying, but also really useful. And I still use it, whenever I'm in clinic, and I've managed to get a few of my colleagues using it as well. It's just things like hitting Control R and it'll bring up a referral template for you rather than having to click through 4 different buttons to get there. And then I was chatting about this to various people, and I did a bit of, I'm not very good at networking, but I went to a few conferences when I was thinking about maybe kind of joining some health tech, doing something in health tech. And I was chatting to a few people, and one of them, Anita, who Mark mentioned, actually put me in touch with Dr. Lydia, who works at Health Tech One as well. She's been away, she's been on a break for a little while, who used to be at Accurex, and I was going to speak to her for a bit of advice and how I might sort of wiggle my way into health tech. And we talked about this automation stuff, and then that turned into why didn't you come and work with us, because we're also doing automation at Health Tech One, which is really cool. So I guess the moral there is that if you do things you're interested in, or that you think are worthwhile, and then talk about them with the right people, they can sometimes open up opportunities to do more of the thing that you're interested in, maybe even for a job, which is quite fun. Does that answer the question, Mark? I think you asked me a few things. So I've rambled.
No, perfectly. And that's really interesting. This if any of you guys, med students and junior doctors or resident doctors now, with your name has changed, which I think is appropriate, of course, you will see there's a lot of health tech companies out there, and it can be difficult to decide who to work for and who not to work for, and that's a conversation in itself, and I won't dig into that. But there's quite a lot of interesting companies out there. Accurex is one of them, who work mainly with GPs, but also secondary care, so hospitals and tertiary care, other hospitals as well, with automating things. There's a lot of automating going on there. Now, you might, sometimes government says RPA, so robotic process automation, is AI. It's not. Just believe us, it's not. It's simply moving a mouse around the screen and clicking on things or typing something on the keyboard for you. It's just automating that whole thing. But Accurex has helped tremendously with the stuff it's doing around messaging patients and doing blood tests and stuff like that. And they've automated things really, really well. But I think everyone in the room here, from the conversations I've had with you all before, have come across barriers when it comes to digital and enabling it and utilizing it. And so Dom and myself use this auto hotkey, which is a program that controls the mouse and so on to do things. But there's pushback on using these things because there's worry about patient safety, about data, cybersecurity, and things like that. But Dom, I just wonder if I can sort of get an overview from yourself of the barriers that you saw in GP land, and sort of maybe the ways you've overcome it in your current role.
That's interesting. There weren't, in terms of kind of hacking around on my own computer, there weren't too many barriers, although you're sort of restricted from what you can install and your computer's really slow. And, I know of a GP colleague who put some more RAM in his NHS supplied computer to try and speed it up, which it did. But then when they found out, they took it away and gave him another crap one to use. So there are some barriers like that. The real problem was that I sort of made this little tool, which was kind of useful, but it was difficult to know how to sort of spread it around and how to ensure that it was like I could use it because I'd made it, and the sort of rough edges were okay because I knew where it would go wrong and how to kind of handle that. But when you want to spread something around and scale it to maybe every GP in the country, let's say, you have to think very hard about what the risks are. So I'm also one of the clinical safety officers at Health Tech One, which means I've spent a lot of time thinking about the risks in what we produce. We don't use auto hotkey, sadly. Actually, I tell a lie, we do use it for one tiny thing, but we don't use it really in our products. So, which isn't to say auto hotkey is bad, but we had to kind of use other tools that are a bit more robust and that you can kind of be a lot more sure about how they behave in certain circumstances. And I suppose what I'm trying to say really is that there are different challenges when you're scaling to a bigger population of users, and that you have to build something that is as foolproof as you can make it, even with very ingenious tools. And that engaging people on clinical safety really early is very important. So I really grateful to the clinical safety officers at the GP practices and the ICBs and federations that we work with for kind of basically reviewing our homework. I produce all these documents, hazard logs and clinical safety case reports, which are quite dry, to be perfectly honest, but they're about basically, what does the program do? And it's, very detailed flowchart. This is what we do. Where do we think it can go wrong? And we have workshops to try and work out where we think it can go wrong, which are quite fun. And what have we done to try and mitigate that going wrong? And so these are, and organizations that we work with are justifiably really keen that we have made something safe and reliable, and that won't, that won't make mistakes, or if it does make mistakes, at least that we have ways of catching them. And so I suppose that's a sort of barrier, but in a way, it's actually it's obviously a really important one, and it's a barrier we're glad to have. I don't know if that's quite what you're asking, but yeah.
Yeah, and that's another role that you from the audience will probably come across is the CSO, the Clinical Safety Officer, a very important role. Not everyone's cup of tea to do it. It can be very dry, but very important. And if you have a good clinical safety officer who helps you navigate the whole difficulty around security, data safety, and enables you to do it safely and secure and so on, they're a fantastic person to have on your team. It's difficult when they're always saying, no, you can't do that, no, you can't do that, no, you can't do that. Computer says no, that's hard work. But if you've got a good CSO, then does a world of wonder to all your projects. Talking about those sort of things, coming over back to you, Chris, I just wonder if I could get sort of, I never got a feel exactly what the sort of work you're doing at the moment in health tech is, but I don't know how much you can divulge if you've got a non-disclosure, but I was wondering what kind of challenging projects you've been working on in digital healthcare, and what did you learn from it?
Thanks, Mark. Yes, don't worry. No significantly limiting NDA. So I work with Elephant Healthcare, who make electronic health records, mainly in use in Nigeria, Kenya, and Pakistan at the moment. So overseas territories. The interesting thing I found joining the company was they're coming from paper systems, and people who have a wide range of. Lots of people, for example, in Nigeria, our main market, do have smartphones, but in their healthcare, it was all paper records, and we had to be faster and more convenient than paper, and that turned out to be quite difficult because they had all the forms that the government needed them to fill in, and to actually make that process quicker and easier for them took quite a bit of work. So that was my first introduction to user experience, and got involved in some user interface design as well, although I'm not naturally a designer. But it showed just the importance of many different roles. The company also has a large operations team on the ground who are going into facilities. It's largely primary healthcare clinics, especially in rural areas. And that sort of on the ground interaction with the end users has been absolutely vital. I don't even think it would be possible to do it without that, to be honest, because getting to see how they use systems, how they overcome problems like power outages or poor connectivity, and then working around those has been very challenging, but very rewarding when you get it right and get good feedback from a facility. As an example, in our web app, it's a web app service, they with cloud storage in country. But there were problems with poor connectivity, so we worked with the engineering team and made a lot of it offline, and with it syncing in the background, and that was transformative for a lot of clinics. So I think it's shown just the multidisciplinary working, like we've alluded to before, in an NHS context, in a sort of product context, having a clinician, which was me, designers, developers, engineers, and then the operations team, as well as marketing and all of that. It's shown that it takes a lot of people to develop and scale a product with that has a good experience for the user. One of the most rewarding things for me was getting involved in finding the requirements for a antenatal care module, and then developing that in line with World Health Organization guidance on optimal antenatal care. So yeah, very enjoyable, interesting. I come across knowledge gaps in myself every day I work with them, and it has shown me a lot about interoperability standards and global health, and touches on all sorts of other areas, which has been absolutely fascinating. So it's not just the code or that sort of thing, but it's really broadened my horizons with what goes into making a product, I think. Does that answer the question, Mark?
Yeah. Yes. Yeah. And there's quite a few questions come off from that, but one of them is, I think you're still practicing, is it 4 days a week? and one day in health tech. So the first question is, how do you balance that sort of different sort of mindset of here's this very digital thing, technical thing, and then the other time GP practice and seeing patients and probably using difficult to use systems as well. How do you manage that sort of change of scene?
Yeah, it's interesting. I quite enjoy the change. I'm naturally a jack of all trades, which is maybe why I ended up in general practice. I love the variety, and I couldn't see myself doing something that wasn't varied. But I find actually the working in different domains like that quite energizing, actually. You're right. There are times when I'm using my my health record in my GP work, I'll not name it. I think, oh, I would have done that differently, but I wonder why they did it that way, and then it opens up lots of questions as to why things are the way they are.
Chris, go ahead. Name and shame.
Emis Web. Yeah.
There's only two to choose from. Let's flip a coin.
There's only Emis or Vision in Northern Ireland anyway. I'm not sure if it's different in England, but yeah. So it's made me think, especially working in Africa, we're trying to help them. The quality of care can be very, very good, but we're trying to support them in getting the basics right and a really good quality of care that's equitable and accessible for everyone, which is one of the issues. So there's sometimes I wish the software that we used was simpler and didn't do as much, but was then much more accessible and easier to use, so that all the members of the team used correct diagnostic coding and managed repeat prescribing the same way and all of this. So, yeah, I think what I've learned also doing general practice in the NHS has given me some insights into what a clinician needs from a health record software. And I think that has been very useful in my private sector work. So I think there's a bit of interplay between the two, but ultimately the variety I really quite enjoy. Yeah.
Yeah, no, fantastic. Leading on from that, I'll come over to you, Paul. Now, I think we all have quite different amounts of time we spend on the digital and so on. And CCIOs can have a range of time that they get given to work on these projects. So normally they go over this allotment. So we have something called PAs. You have 10 PAs. So it's basically a morning and afternoon session for things. And depending on how big a hospital is, you can have like your whole week filled with sort of this CCIO work. But normally you only get one or two. Just a quick question to start with, Paul. How much time do you get given for this work? And then after that, how much time do you actually do in digital?
Yeah, you're absolutely right. In my contract, my CCIO time is 2 PAs, which amounts to 1 day a week, which I do on a Monday. And yeah, I spend a lot more time than that actually doing CCIO related work, because there are always meetings that you have to attend, or just other jobs that you need to do that you can't just fit into 1 day, because as with a lot of things in medicine, but particularly in digital, you don't work alone and you work with a very broad team. We're in the process of implementing an EPR at the moment. So we've got project managers, change leads, training people, configuration leads, configuration analysts, a whole range of people, never mind the clinical staff who have to use the system. So to try and make everyone available when I'm available is almost impossible. So you do have to have a bit of flexibility, but equally, yeah, you do end up doing more than the allocated PAs that you have.
Yeah. Thank you. Now, EPR, for everyone that was listening, electronic patient record system. There's also EMR, EHR. It's all the same thing, health or medical. And it's the thing you'll be using your most when you come out of med school. It'd be in GP practice, they have their own, and in hospitals, there's many, many more. There's only 2 GP ones. Well, there's 3 technically, but there's only 2 major ones. Yeah, EPRs are, I could talk for length about them, how they're good and bad and all sorts. But I wanted to get your thoughts, Paul, on how the clinician helps, because you could just have someone who's a software engineer and they build something and throw it at us clinicians, which it feels like most of the time is what happens. But I wanted to get your take on, how do you feel that a clinician plays a larger role in the design and implementation of healthcare technology?
Yeah, I suppose that there are two aspects to that. There's one, how does a clinician contribute to the build? And how does a clinician contribute to the implementation? And that follows the, if you like, the kind of clinical safety framework, because of course there are two areas of legislation that you have to meet when you're developing digital products. One is the manufacturer's obligations, and the other is the organization's obligations of how they implement the solution. Obviously, if you design a system with the people who are actually intended to use it, you're far more likely to develop a solution that works for the people who are going to use it. And in theory, this must happen. You know, we're implementing an EPR. I can't believe for a second that clinicians weren't involved at some point in the design of that. Although when you actually see it, you really would wonder. But in particular with the EPR we have, a lot of it is configurable. So a lot of the work that we will do over the next few months and probably the next few years will be configuring and refining and optimizing the solution to fit the workflows in our organization. And we're a very specific organization, unlike many trusts that people will encounter, certainly people on this call. We're the second smallest trust in the country, and we only really have four specialties on site. So we're very surgically focused, with the sleep medicine bit being a slight anomaly to that. But everything is designed around getting people into and out of the hospital through a surgical pathway safely and efficiently, which is quite different to a hospital that's got a big ED and a large medical department and lots of medical wards. So a lot of the work I'll be doing is to try and tailor the solution that we've purchased to try and enable that pathway to be as safe and efficient as possible, and as easy to use for clinicians as possible, because as we've alluded to, a lot of the time the systems we're given are very cumbersome. They involve lots of clicking or lots of integrating other things that aren't the same program, they're different ones, and trying to bolt all that together in a way that isn't painful.
No, I think that's really important. And I'm a very big advocate of end user design, which basically means designing the system you use to be as easy to use as any app on your smartphone. You know, it's intuitive, it's quick, it's smooth, it's flawless, it doesn't break, and it does what you need as quickly as possible. Why we haven't got an app store for healthcare systems and people just choose the app they like, and then and the good apps will thrive and the bad apps won't. We haven't got anything like that. Maybe one day, maybe it's a bad idea, who knows? But yeah, it's all about building the functionality and the user experience, the thing you see on the screen and how it works to work with us rather than against us. And unfortunately, when you get onto the wards and GP practices, you will see these systems that don't work that well. And digital can enable, and I fully believe this, digital can enable better healthcare. It's just we haven't realized it yet. And it's a global issue. It's nothing to do with the UK. It's a global issue. And there's many reasons why we haven't had those systems. I will not go into that. Built the way we need them, on a whole. But yeah, it's crazy. Chris, I'll come back to you actually, just leading on from this sort of discussion. Around your digital work and even your healthcare work, I was wondering, how do you ensure that the digital health systems that you and your company build are accessible and equitable for all patients, so everyone has the access to these things, and even those that are digitally illiterate is that something you thought about, or the dexterity issues of the rheumatoid arthritis hands and all these sort of things which sometimes get left at the wayside. I was wondering to sort of hear from yourself about what you've done to manage that accessibility and so on.
Yeah, thanks, Mark. Yeah, accessibility is so important if you're going to make something that can be used by anyone that needs to use it. Yeah, I suppose the two sides for the electronic health record are the clinical user, which for our software can be anyone from a clinic administrative person to a nurse, a doctor, and various other roles as well, such as a clinic manager. The one issue we had is we're starting from scratch in a lot of the facilities from paper. And a very high variability of digital literacy. Many clinicians were absolutely fine with using computers and tablets. Many other people required additional training for that. So our operations team go in and provide training in the use of tablets and so on. Often the tablets are included as a package as well. And then with a lot of tablets, you will have various accessibility features such as magnifiers, text size, variability, and things like that. It also supports external keyboards for people who want that as well. So a range of input devices with hopefully an intuitive and simple, it's quite a streamlined user interface, which supports assistive technologies, for example, like VoiceOver, if you've used that on iPhones. So there's a sort of a multi-pronged approach. For patients, we have there is a simple patient portal. That's something that may well change and become more complete. And again, sort of dependent, of course, on access to computers, which is or smartphone, which in itself can be not an equitable thing. And we had to decide that yes, this is for people who have access to that, but whatever that means, because actually smartphone ownership is quite prevalent there. But we had to make it, again, simple, potentially multilingual interface as well that can be selected. And again, with a few other accessibility things like controlling the amount of information displayed and text size and so on. So thankfully, our designer has a lot of experience in making interfaces accessible, and I'm glad they were in charge of that, because that is an art form all in itself. And there have been many times actually I've envied the simplicity of that interface when I'm using the behemoth that that is my GP software. So yeah, sort of there was those two sides to it, clinical, but also patients as well. And we had to make sure as well that the software we were using didn't disadvantage certain patient groups. So that was a bit more of a nebulous one, perhaps. Especially when we get into specific patient modules that were not avoiding dealing with or providing functionality that supports the management of diseases just because they're difficult or just because we don't have them here in the UK, so managing things like malaria and so on, which is a huge issue there. And again, that in our case came down to a lot of work with the operations team, ensuring sort of equitable training and even sort of patient outreach around facilities that were implementing the software to make sure patients knew what it was, that they had informed consent to use their data and information, and that they were as on board as possible with why it might be helpful to have an up-to-date record that they can access. So yeah, hopefully that answers that, Mark.
Yeah, no, thank you so much. Thank you so much. Now, Dom, over to you. A slight change of tack, so hopefully this doesn't take you off by guard. But I wonder if you could tell me a bit about the ethics around digital healthcare tools. We learn about ethics quite a lot at med school, and then we kind of forget about it a bit, but still use it here and there. But there's a lot of ethics behind, digitizing things, AI, and actually sending patient-related data, pseudo-anonymized or however it is, to the large language model that is ChatGPT and related models and other things. And I was wondering if you could tell me about the sort of ethics that you see that might be an issue or well managed even around digital healthcare. That's next.
As a great example of this, if we send out, let's say, booking links by text message, that's great for maybe 60-70% of our patients, but there's quite a big chunk who just don't handle technology well, and are confused, frustrated, or totally unable to reply to a text message or click on a link in one. These things will change over time, but that's kind of a really important aspect of building anything, is thinking about the subset of users people who won't be able to use it, and what the provisions are for them. There's lots of ethical things around digital health, right? Like there's ethical considerations in doing less medical work and going to work at the startup. Chris, I'm amazed you're doing 4 days a week as a yeah, everyone slides off the camera. 4 days a week as a GP, I just about manage one, and I frequently feel like I should do more, but it's really hard to kind of to find time for everything. And I remember when I started here, I was like, I've just done all this training to be a doctor, and now I'm going to go do less of it. And I think, on a personal level, I was like, maybe I can have more impact making kind of cool, techie tools and doing things here than I would as an individual GP. So there's that ethical consideration on a personal level. And, I suppose if you are making something that scales, we have 1,000 GP practices as our customers now, which is about 15% of the about 6,100 GP practices in the country. So stuff that we do has a huge impact. So we have an ethical duty to do a good job, and to do all that clinical safety stuff we were talking about. To think very hard about how we do things. You also mentioned AI. We can make this more of a chat. I don't have to feel like I'm doing a lecture. I was actually thinking about AI earlier when Paul, when you were talking about R and how powerful it was for you to be able to pull up, make a little website with an interactive demo and stuff like that. And I've been playing around a lot with one of the AI tools called Claude, which I'm sure many of you have already heard of. I like it because it has this thing called artifacts, where if you ask it to you can say, make me a little tool to take this kind of data and produce a graph, or make me an interactive tool to explore this data. Give it either just like some sample data or the actual data that you want to play with, and then it will sort of whip up a little website which it puts in a demo page on the side. Sorry, I've veered off ethics, but this is really cool. So
no, please.
If anyone listening hasn't played with this, try it out. If you give it, there's the data format, whether it's like a spreadsheet, Excel style, comma separated spreadsheet format. Tell it what you want to do with it. Maybe it's just explore this data. Maybe it's break it down in these ways. It's really, really amazing at producing a little website tool. It'll show you the code and it'll run it in the browser, and then you can tell it that you want to upload a data file. So then you're not actually giving all the data to the AI. You can just download that web page and run it locally, and then it avoids kind of risks about if you do have patient data on your end that you want to analyze or do something with. You can still get the AI to make you a tool that you can then use in a safe way. But if you are playing with these AI tools, be very careful what you feed into them, and don't give them patient data, because we don't really know where it's going. I'd say.
No, exactly. So all these large language models actually use the data you give them to learn from. So don't put in anything that's patient related, definitely. So we had a few questions on here. We'll catch up content and be uploaded later. So I think this is all being recorded. But if you want to learn anything more about what we're talking about or contact us, you can contact us at info@letsdodigital.org or contact the Mind the Bleep team. I can put you in contact with Paul, Dom, or Chris if you want to get in contact with them. And Marisol's asking about, for clinical safety, what strategies are you using on decommissioning systems? Thanks. I think there are some standards out there for doing it. I don't know if it's like a DCB standard out there. I don't know if anyone in the room knows how we decommission systems in a standardized way. I haven't been involved with that myself.
Yeah, it depends really on what you mean by decommissioning systems. I mean, clinical safety, as in the clinical safety framework, is related to digital health products. So it's not related to hardware. That's medical devices or your IT equipment. So that's a different sort of decommissioning. Decommissioning a piece of clinical software, really what it comes down to is, where is the data? How is it going to be persisted, or how is it going to be destroyed? And that falls into the DCB 0160 framework of implementation of clinical systems. So at the beginning of a project, you actually decide how you're going to end the project as well. So you always have to have a plan for where will the data be, how will it remain accessible. If it can't remain accessible, is it actually going to meet the rules on, for instance, if it's a health record, you have to persist that record for a number of years. And that number of years depends on what it's about. If it's for pediatric conditions, that is often lifelong, whereas just standard stuff is usually 7 years after the last contact. So there's an information governance aspect there, which is usually helped by your information governance officer, because the CXIO, the clinical safety officer, and the information governance lead all tend to work pretty closely together, because we all have just slightly different aspects of the same thing to deal with. So really the main strategy is to have the plan set out in your clinical safety case report and your case management file, and it's different for different digital products, but if it's written out and well documented at the start, then it should be quite clearly open to governance and assurance at the end.
Fantastic, thank you, Paul. Now, for the last section of this webinar, I want to go into education and learning how to get to where we are. I would say us four here in the room are sort of midway through getting to the top, or at the top even, of being a clinical information. No, Chris and Dom say no, but I say Paul, who's a CCIO, technically is at the top. You know, you can only be any higher if he was the national CCIO. Maybe aspires to that or not.
No,
but
thanks.
But I'd really like to get your thoughts, Paul, on, because you do teaching courses in R and so on. I'd really like to get your thoughts on, you know, we've got where we are. How do people listening now, you know, get to where we are, or even start that process? Because I think all of us and everyone I've spoken to, there's no career path for this. You kind of fall into it most of the time. You know someone and you sort of get into this thing, or you can code a bit and someone says, you know, you can fix the printer, you can fix the EPR. I was just wondering if you could give sort of your thoughts on how people could actually get onto a career ladder in this specialty.
Yeah, I think you can summarize it by saying stumbling in the dark. Because I think that's probably how most of us got through it. And I think given my vintage, I probably stumbled in a darker period than some of you. But I mean, I think it starts off with having an interest in it and developing some skills, whatever they may be. And the skills you need are very varied. You can be a CCIO with no coding skills whatsoever, because a lot of the CCIO role is about digital transformation, change management, education, providing assurance, understanding what the systems should do and how they should be certified. But I think most of us have touched on things like coding or application design or website design at some point along the way. Most of what we've learned by ourselves, either self-taught or, you know, through coding communities, online courses, that sort of thing. And that's now more accessible than it has ever been in history. So accessibility to learning how to do technical things with computers is around, and it's very accessible. Then to work out how to apply that stuff in healthcare, really, the way I became a CCIO was that I went to my predecessor and said, "Do you need some help?" And he said, "Oh my God, yes, thank you." Then promptly retired, and I got his post. But that's it. You know, it's finding your way into the system, and if you're enthusiastic, if you've got some skills or some knowledge that you can apply, then finding the person who does the job and asking if you can help is probably your best bet. And then in terms of more formal training, I did the NHS Digital Academy at the same time as Mark, which did provide some formal training in digital health leadership. And that's the CXIO roles are all about digital health leadership, rather than necessarily technical coding skills or any sort of IT skill. So that does give some legitimacy to what you're claiming to be able to do, because you've actually been through it, and yet you have a certificate at the end that says you've got a bit of training. And yeah, I'll just keep stumbling.
That's how it feels. It does. But happy stumbling, maybe slightly tipsy stumbling. Maybe that's the best way to describe it. Now, Chris, I'd like to come to you. And the reason is because you and me kind of are practicing this at Let's Do Digital, tutoring and mentorship. So we used to have mentors in the FCI, the Faculty of Clinical Informatics. And something we're doing at the Let's Do Digital, and we're doing some coding courses. If you're interested, we do a plug there at Let's Do Digital, and Chris is helping us do those courses in Python and learning how to use Python, in healthcare. But I think the more general question I think is, how can people find mentors or tutors, and how can we help enable, med students and doctors at the beginning of the career to actually progress in this specialty? Because unfortunately, there's no training number in clinical informatics. So you can't just sort of apply for a training and get onto it, and then 5 years later, you're a clinical informatician, CCIO, whatever. I'd really like to get your thoughts on how can we, who are already on this career path, which doesn't really technically exist, help others?
Thanks, Mark. Yes, I found, in my personal experience, I started learning to code, started with Python. Good place to start. Obviously, you don't have to learn to code, as we've said. But for me, that was interesting. And actually, at the time, I had a spreadsheet to keep track of the drugs in my medical bag, and then made that into an app because I never looked at the spreadsheets. And then the app told me when they were getting towards their expiry date. But for me, it started in that way. And then I realized there's this whole community out there. So I joined the Digital Health Networks, the NHS PICOM community that Mark's involved in, and through just observing conversations there, got to know how that worked, and then got to network with some people. So it was sort of a slow, organic thing in my case. And the one thing I would say is I wish I'd probably started the journey earlier in my medical career. But in terms of helping, I think courses like Let's Do Digital, or even independent coding courses as well. Starting out there, or Digital Health Academy. What I would say is, on the ground in the NHS, speak to one of the information management team, I guess, in your trust or your facility. Benefit there, I think, would be they can let you know what is being worked on, where any help might be needed, and I think that's probably quite a practical way that you might be able to get involved. So approaching the local team. I have to say, until when I started out, I didn't know who the CCIO was for. It was Belfast Trust here at the time, but now I find it better connected. So I think that networking, getting to know some people, getting involved in some of the online communities is vital. And I find there's a lot of knowledge sharing can go on there as well. The NHS context in Northern Ireland is a little bit different, but I then learned a lot about the digital health in the NHS through a number of resources, largely through Digital Health Networks. And there's a book, I think, by Gary McAllister that give a background to digital health in the NHS as well. So there's a lot of resources there. So yeah, I guess I haven't really addressed their sort of helping each other, but I think reaching out, discussing it, and finding how things operate locally for you, and where those opportunities are to get involved, and then perhaps guiding your learning based on what your interest is or what way you want to get involved. And I suppose my take-home message is that can be one of a number of different approaches or roles.
Yeah, I think that's right. I mean, my experience at the moment is that, for instance, I have a trainee in anaesthetics who expressed an interest in digital, had obviously been discussing this with one of their consultant colleagues who said, you need to go and speak to Paul because he's the CCIO. So he's now taken on a project, and it was a project that had been sort of floundering a bit, but because he was new blood coming into the project, hugely enthusiastic, we have turned that around. It's going to be going live very soon. It's a digital pre-assessment system, which will be a huge benefit to the organization. But he would not have found that if he hadn't expressed his interest in digital in conversations with his seniors, who were then able to signpost him to the right person. So I think that is probably the key for actually getting any on-the-job practical project experience. You need to find the team that are doing it in your trust or whatever organization you're working in, and then reach out.
I think that's a really important take-home message for anyone that's interested in this career path. I'll stop using inverted commas. Is being proactive and actually going out there and asking, can I get involved with a digital health program project, however small or big? Because there's lots of them out there. The government's throwing money at this, basically. Companies are throwing money at this, basically, for the better or worse. And if you want to get involved with this, just raise your hand, find people, and talk to them and say, I'm interested, I want to help. And that's how most of us got into this. Now, coming back to you, Dom, I think you and me and our colleagues, we have a little WhatsApp group, have a lot of chats in London and further afield about trends in digital healthcare, what's sexy, what's not, what's happening, what's going forwards. And I was wondering, for people who are listening, how can they best stay up to date with current trends, sort of, try and understand what's actually, snake oil, what is actually something that's beneficial to patients and healthcare staff. I just wonder if you could sort of elaborate on how you keep up to date and, make sure you understand what's going on in the world in digital healthcare.
Good question. Yeah, it's a really good question. I think, ultimately it's curiosity, isn't it? And sort of reading a lot and being kind of active online and keeping your eyes open. But you hinted at one that there's a couple of WhatsApp groups. There's and the only way you'll find out about those is if you speak to other people who are interested in the same things. So it really does come to, I know it sounds awful, doesn't it? It really does come down to sort of networking in the end, which is I always thought was a bit of a dirty word. But the only way you'll really hear about what's going on and on the ground is from other people. And there are some kind of central resources. There's the what's it called? Digital Health Forums. Have you got a link handy, Mark? You can stick it in the chat. That was actually
Discourse.
Discourse, yeah, exactly, the Discourse. Which is actually where how I met Anita, who has come up a few times. But
it's her fault, yeah.
Yeah, exactly. He basically got me my job and put me in touch with Mark as well in the first place. She's the great connector. But the Discourse forums are a really great place where there's lots of CCIOs and similar sort of people hang out, and so lots of kind of new technologies are discussed on there, partly from a kind of rollout safety point of view, but also just from a curiosity and kind of experimenting with this. There's a clinicians who code section on there as well, which is where I met some good people. And then I think if you're sort of interested in tech, then there are lots of kind of good resources for tech news. Like I really like the website Hacker News, which is kind of like a standard sort of blog, like it's like slightly old school looking blog place but people post interesting tech news, and often that's to do with AI or health stuff, so it has got lots of crossover impact, and that's always worth looking at. In terms of what's snake oil and what's not, I don't know. I think you just have to keep your eyes peeled and develop an intuition. I don't know, Paul, you must have seen a lot of snake oil in your.
Oh yeah, and I continue to do so. I suppose the other thing, I don't know if anyone mentioned, there's obviously Digital Health Rewired each year, which is a digital health conference, and it's a good way to meet a bunch of people, meet a bunch of suppliers, and hear a number of talks over a very broad range of digital health topics. And for people who are interested, if you're doing something interesting in digital health, then think about getting a poster or a presentation presented there, because that's one way of getting yourself into the system and being seen as someone interested in digital health.
Yeah, fantastic. Thank you both. And Let's Do Digital has a conference as well, Let's Talk Digital, where you can submit posters, video posters we call posters. So, please come along to the one next summer. Oh, there it is. He did it. He finally showed his true colors.
8 minutes.
Very nice. Thank you so much. No, thank you all. Thank you, Paul and Dom and Chris, for coming along and telling about your lives, how you got to where you are, and how other people could try and mimic what you've done. And I was thinking, I'm just going to hopefully end with a simple answer from each of you, a sentence answer from each of you to this question, and see how it goes. And we'll start with you, Paul. If you give your one piece of advice to your younger self as a junior doctor, what would it be in relation to digital health?
Gosh, start sooner.
Fantastic. Dom?
Yeah, I'm sorry, I'm gonna steal that. I was gonna say go less than full time and chat and find interesting things to do in the gaps, and that would probably be talking to finding out who's responsible for the digital stuff that you already work with, and worm your way in there.
Fantastic. And Chris?
Perfect. I would echo those sentiments. Start earlier. I didn't start learning to code until my early 30s. So if you're younger than that, there is time. I would say in your day-to-day work, looking out for a problem and thinking how you could solve it is, as a general approach, can be helpful and can cultivate in you a sort of a mindset of just identifying. That's how often our startups are born, is like, or how change happens in something like the NHS is see a problem and work out a way to fix it. The rest of how that's done is often just then good bookkeeping, and implementing it. But look for problems and think how they might be solved. So, yeah.
And I'm going to ask myself that question as well. And it would be reach out to people that are doing this and get involved. And that means I'm putting my hand up. If you want to contact me or anyone else in the room, please contact us. I want to see more people doing what we're doing. There's not enough clinical informaticians out here to help make digital health better.
Thanks.
On a happy note,
yeah,
I want to say thank you again to everyone that joined us in the audience, and Paul, Dom, and Chris. It's been great talking to you all, and hope you have a nice evening. And yeah, let's talk again later.
Thanks, everyone.
Thanks, everyone.
Good to see you all.
Thanks, everybody.
Catch you soon. Bye.
Bye-bye.
Cheers, guys. I'm going to head off now. Thank you so much.
Cool. Cheers, Mark. Thanks.
Thanks, Mark.
Bye, Dom. See you.